Good evening, everyone. I welcome you all on behalf of ACP India chapter. And today we are here in the month of hypertension for a very, very special episode, the ACP India case files. And as you all know, the ACP India case file was recently awarded by John Tucker Evergreen Award at the Internal Medicine meeting at Chicago last month only. And this program was widely appreciated and acknowledged globally. And today we have very, very eminent faculty with us. And to take us through this program, I would like to invite Dr. Anuj Maheshwari, who is the governor of ACP India chapter. And Dr. Anuj Maheshwari, you all know, he is professor and head Department of Medicine at Babu Banarsidass University, Lucknow. He is a PhD and DNB teacher. He had fellowship of all the reputed international and national organizations. He is also the vice president of RSSTI, and he has worked greatly in the field of diabetes, hypertension, as well as the other medical disorders. He has also been awardee of BC Bansal Oration, as well as many other prestigious orations and award to his credit. So I will request Dr. Anuj Maheshwari sir to please take over for this episode of ACP India Case Files.
Thank you, Amit. I welcome on behalf of American College of Physicians India chapter to all the attendees. I pass on my greetings to all people, all doctors, those who are attending from India as well as from out of India. Welcome you all. As you all know that this program has been very specially structured, and it is especially meant for the early career physician. Early career physicians, those who are in their first 5-6 years of their practice after passing out their final examination. So it is very much important for them how to do the planning for their future. It is very much important for them how to keep themselves fit from the busy schedule, during the busy schedule. At the same time, it is also very much needed that how they could keep their well-being ensured. Apart from that, we also realize that CME pattern of imparting knowledge may not work very well for the early career physician because they have just passed out, almost they are well read. So we focus on the clinical problems, the case-based problems, clinical problems, what they usually face in their day-to-day life whenever they are coming across patients dealing from one hospital, another hospital, clinics, and wherever. So we always request in this program to one of the very reputed teacher and professor who tells about his own experiences regarding particular topic and some especially interested cases which he might have come across in his life. And today we are having Dr. Nihal Thomas for the same. He is from CMC Vellore. And apart from this program will be run by Dr. Rakesh Sahai. Dr. Rakesh Sahai does not need an introduction for the doctors of India at least, because he is the he has been just president of the Endocrine Society of India recently. Presently, he is professor and head Department of Endocrinology, Osmania Medical College and Hospital. He is the consultant endocrinologist and at Sahai's Endocrine Diabetes Center in Hyderabad. Apart from that, as I said, that he has been the president of the Endocrine Society of India. He is vice president of the South Asian Federation of Endocrine Society, section editor, tropical endocrinology, and editorial board member of the IJEM, National EC member of RSSDI, organizing secretary of the RSSDI National Conference 2016. Lot of awards in his credit, apart from the publications, at least more than 150 publications in various national and international journals. He has authored a lot of chapters in various textbooks and monographs on diabetes and endocrinology. So Dr. Rakesh Kumar Sahai is the absolutely fit person to run this session, which will be in first half on the very interesting case of endocrine approach of the hypertension, or approach of the endocrine hypertension, what we can say. And second half, we shall be talking about a dietary pattern or eating schedule of a busy clinician. How can he keep himself fit while being so much of busy? Dr. Rakesh Sahai, I hand over the podium to Dr. Rakesh Sahai to run the rest of the session. Over to Dr. Rakesh.
Thank you, Dr. Anuj Maheshwari, for the kind words of introduction and for introducing me to this show, to this program. I think this is a very important program which is run by the ACP India, and I think it is serving a very important purpose of educating all the earlier career physicians and addressing many clinical problems. And today, in that series, we have a very eminent speaker with us, Dr. Nihal Thomas, who's the associate director of CMC Vellore. He is professor and head of Department of Endocrinology at Christian Medical College, Vellore. He has been deputy superintendent, vice principal in research, and held several positions in the past in the Christian Medical College, Vellore, which is a very important and prestigious institution in South India. He has more than 300 index publications in various national and international journals. He has several chapters and he has brought out two important textbooks also, and he's been very actively involved in various aspects of endocrinology. His work in Modi has been very well cited everywhere across the world, and he also has important contributions in different aspects of endocrinology. He has been running several research projects in the Department of Endocrinology at CMC Vellore, and the Royal College of Physicians awarded Excellence Award to CMC Vellore, the Department of Diabetology and Endocrinology at CMC Vellore, for their excellent services that are being rendered by this department. So I have great pleasure in introducing Dr. Nihal Thomas, who's going to speak on a very equally important topic of endocrine hypertension, because we know that hypertension is very common nowadays. The prevalence of hypertension is quite significant. I mean, more than 30% prevalence of hypertension, and amongst the hypertensives, I think almost as high as 10% could be endocrine hypertension. And Dr. Nihal is going to take us through that, show us when we should suspect endocrine hypertension, how we should assess that, and how should we manage that. So it's a long topic that he has got to cover in the short time that he has got. So I'm sure he is going to make it interesting and give us some important take-home points. Over to Dr. Nihal.
Thank you, Dr. Rakesh. Thank you, Dr. Anuj and Dr. Amit. It's a privilege to be here today, and thank you for once again giving me the opportunity to speak to your early career physicians on this topic of endocrine hypertension. And I'll try and make it largely case-based. So this is what I'm going to be covering: an introduction and the broad differential diagnosis, a bit about the catecholamine-inducing tumors, hyperaldosteronism, Cushing Syndrome, and finally a broad clinical approach towards these conditions. So if you look at the etiology of endocrine hypertension, we have the landmark disorders, essentially pheochromocytoma and paragangliomas, hyperaldosteronism, and Cushing syndrome. We also have other rarer conditions which we as endocrinologists should be thinking about, like 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency, which we seldom see in general practice, and therefore I won't be covering those in much detail. And then, of course, you have disorders which are common endocrine disorders. Having said that, these disorders themselves stand out, and hypertension is a bystander amongst the clinical presentation, hyperthyroidism and hypothyroidism. But I should make an important declaration, and that the commoner causes for hypertension, secondary hypertension, are not endocrine. And even as endocrinologists and general physicians, we should be aware that ruling out chronic renal failure, glomerulonephritis, and renal artery stenosis, and vesico-urethral reflux, which is very often missed as important causes for hypertension, should be first thought about before we allude towards endocrine causes. And then there are other causes, including coarctation of aorta, secondary to raised intracranial tension, and porphyria, which of course could present with episodic hypertension. So these are the commoner causes that I would highlight. Now, when we think about endocrine cause for hypertension, we need to know the normal from the abnormal. And this is a study which has looked at the size of adrenal glands, which was computed in our institution by our radiologists in collaboration with our department. And you can see over here that the mean thickness of the right side is slightly less than that of the left side. Besides, we're having a difference in shape, that there is a difference in size, and the cumulative volumetric thickness is greater on the left side than the right side. Interestingly, it's also slightly greater in males compared to females in Indian patients. So we'll first go to pheochromocytomas and paragangliomas. The first series published in India, a large series done by my teachers, Professor Sheshadri and Arvind Nair, almost perhaps 25 years ago. And this was published in the Australian Journal of Surgery, looking at 33 cases. We have gone through a paradigm shift in our diagnostic approach from doing largely angiograms of the abdomen, then moving to CT scans. And now, of course, we're looking for more diffuse disease. We use PET scans. As far as biochemical testing, we have moved from the vanillin mandelic acid testing, which was cheap, easy to do, to the more sophisticated metanephrine testing using urine fractionated metanephrines. And of course, plasma catecholamines can be used. However, they are expensive and they've not become the standard of care in our Indian setting. These are studies which have been done by our department, spearheaded by my colleague, Dr. Simon Rajaratnam, in connection with pheochromocytomas and paragangliomas with regards to genetic testing. And I think now genetic testing is extremely important when we think about endocrine hypertension, when we think about pheos and paragangliomas, because familial disorders are present in almost 30%. It's no longer the 10% tumor. It is perhaps much more than a 10% tumor when it comes to inherited disorders. And therefore, predictive screening of these disorders and families is a very important thing, which can help in early diagnosis and better prognostication when we treat these conditions. So when we think about the familial conditions, the common familial conditions, multiple endocrine neoplasia type 2, which is A and B, which has the RET mutations, von Hippel-Lindau syndrome, which has the von Hippel-Lindau mutation, the paragangliomas and pheochromocytoma syndromes due to SDH or succinyl dehydrogenase deficiency mutations, SDHB, the one which is very often much more diffusely spread and more malignant, and the SDHD mutations. There is an important role before we go on to the cases per se and to understand them, because they help particularly in patients who have paragangliomas, those with bilateral adrenal tumors, unilateral adrenal pheochromocytomas with a family history, unilateral adrenal pheos who come at an age less than 45 years, and other clinical findings suggestive of an associated syndromic disorder. So here we have a 44-year-old gentleman who came with a history of severe hypertension for 2 years and a recent onset of diabetes. We look at his urinary metanephrines and his normetanephrines. I should put an arbitrary cutoff of 600, and these are essentially normal. But his serum calcium is elevated with an elevated parathyroid hormone, indicating that he certainly has hyperparathyroidism. You put 2 and 2 together, certainly hyperparathyroidism per se can cause associated hypertension by stimulating the renin-aldosterone system, by stimulating aldosterone production. However, this patient we pursued further, and imaging showed evidence of bilateral adrenal tumors. And this was further confirmed by an isotope scan called a meta-iodobenzyl guanidine scan, a cheap and easily available scan which has been available for the last 3 decades in our institution, and confirming the presence of bilateral catecholamine-producing tumors, despite the fact that the patient did not have elevated urinary metanephrines or normetanephrines. So these lesions basically are present and they can be pre-biochemical, and therefore it's important to understand that patients who have paragangliomas or pheochromocytomas can present with normal catecholamine levels in about 10 to 15% of tumors. The ultrasound of the neck showed a parathyroid adenoma, and in this situation, he underwent treatment of the more dangerous tumors, and that's the catecholamine producing ones. Bilateral adrenalectomy was performed. He subsequently had excision of the right parathyroid adenoma, and because of a patient who had parathyroid adenomas and pheochromocytomas, we think of the possibility of a MEN2 syndrome. So this patient had a medullary thyroid cancer along with the parathyroid adenoma and underwent a total thyroidectomy. So this is a diagnosis of MEN2A, and he has since then remained well and asymptomatic for the last 20 years. So we have looked at the mutation analysis for multiple endocrine neoplasia, and this was published about a decade back in 2011. And the mutations are no different from what is seen in Western literature. Why do we do this? It helps in doing prophylactic thyroidectomies. If you make an early diagnosis in a family, then you should screen the children, and the children are positive. You should do an early thyroidectomy before the age of 5 years. And perhaps even do a prophylactic adrenalectomy in some of these patients once you see an adrenal gland enlarging. So certain mutations with codon 918 and MEN2 indicate a poorer prognosis and a more rapid progression, and therefore predictive screening is very important. 18-year-old lady came with severe hypertension for 3 months, had massively elevated norepinephrine levels. Obviously, at the age of 18, the likelihood of it being pathological is high. So we did a routine screening with the renal functions, electrolytes, and the metanephrines, and which were high. CT scan showed bilateral adrenal tumors, a much larger left-sided tumor, about 7 centimeters with areas of necrosis, and the left side, which was 2 centimeters in size. Now, in addition, the CT scan incidentally showed evidence of a pancreatic vascular lesion. And so when you have bilateral adrenal tumors with a pancreatic tumor, you should think of von Hippel-Lindau syndrome. The isotope scan, the MIBG once again shows evidence of a right-sided adrenal lesion. And yes, a right-sided adrenal lesion, which is quite prominent in addition. So she underwent a right adrenalectomy. Now, because she has bilateral tumors, one might think if you take off both adrenals, you can cure the disease. But at the same time, you may need to replace the patient with glucocorticoids and mineralocorticoids, prednisolone and fluticasone in addition. But what our surgeons are adept in doing is they took off the large tumor with the adrenal, and they actually spared the cortex on the left side. As a result, the patient did not require long-term glucocorticoids and mineralocorticoid replacement. The pancreatic tumor was also excised, because even though these are very often non-functional, in a subset they could become enlarged, cause mechanical symptoms, and also malignancy is an occasional possibility. This is the histopathology, and it's important to remember that these tumors are vascular and very mitotic. So mitosis per se does not indicate malignancy. It's malignant only when it shows vascular invasion or capsular invasion, or it shows metastasis when you're talking about a pheochromocytoma or a paraganglioma. Post-op, it was uneventful, and as per our protocol, we did genetics testing. You can see over here that despite the fact there were no retinal angiomas, which is also another important finding in the fundus of patients who have von Hippel-Lindau syndrome, the diagnosis of von Hippel-Lindau syndrome was confirmed with genetic testing. And this is very important because VHL is the commonest cause for a familial pheochromocytoma. This is the mechanism, and you can see that it is due to increased angiogenesis by accumulation of VEGF, increased glucose transport, which leads to increased growth of the tumor per se. And so these are the features of von Hippel-Lindau syndrome. Now, in apparently non-syndromic familial disease, von Hippel-Lindau mutations were the most common occurrence in our series. And we need to follow them annually because they are prone for vascular tumors in other parts of the body. They need a periodic MRI brain, spinal cord, at least once in 2 to 3 years. And they need a CT abdomen to see if there's any recurrence in these tumors or pancreatic tumors emerging. And of course, optic fundoscopy on an annual basis is required. If they have threatening angiomas in the retina, they need to be treated with anti-VEGF treatment or laser therapy. So what is our algorithm for patients with tumors and paragangliomas? we need to do urinary metanephrines and norepinephrines. CT scan is preferred over MRI in most situations, and the MIBG DOTA PET scan is done to perform to locate extraadrenal lesions which are undiscernible or metastatic. The only cause for hypertension where we load with fluid or sodium and salt is pheochromocytomas and paragangliomas. So you need to load them with fluid about 4 to 5 liters per day for about 10 to 15 days, and also give them alpha blockade prophylactically. The treatment of choice is phenoxybenzamine, but prazosin works just as well and is much cheaper. We start them on beta blockade because they can develop tachycardia, but you do this only after about a week to 10 days. If you start it too early, you can actually get a catecholamine crisis. If they are left-sided and large, we give prophylactic pneumovax. What about calcium channel blockers? Well, certain series have shown that calcium channel blockers seem to work equally well. We are used to alpha blockade, and physiologically, of course, we feel that it works better. And so that's our protocol that we follow in our center. Surgery, of course, these are the standard gases which are used. They do not stimulate catecholamine production as much as the older forms of treatment like nitric oxide and halothane, which no one uses anymore. Treatment can be done for large tumors even with the laparoscopic method, and our endocrine surgeons are pretty adept in doing this. If you have multiple tumors or you have local invasion, then you prefer open surgery. And here is a malignant tumor being excised and blocked with open surgery. 31-year-old gentleman, the eldest sibling, presented with 4 months of history of recurrent hypertension, palpitations, flushing, and headache. We had very high blood pressure, noticed swellings on either side of the neck, and urinary norepinephrine levels were elevated. The normal levels up to 600 once again. You can see that what he had was this very vascular lesion. As you can see, it is enhancing in the arterial phase over here. And the MRI brain and neck showing evidence of bilateral carotid body tumors, which are very vascular. The isotope scan also shows a positive uptake. So blood pressure was controlled after laparotomy, and also the 3 lesions were excised, and histopathology confirmed the diagnosis. A post-operative MIBG scan was negative. Subsequently, on follow-up, we see recurrence in the neck with a DOTA PET scan. And this was treated with lutetium, with which there was some regression, but there was still presence of tumors over there. Patient is currently on follow-up and has no complaints. This is a series published by my colleagues, Dr. Nitin Kapoor and Simon, looking at the carotid body tumor experience in our institution. Here is a 25-year-old lady who came with right hemiparesis following an intracranial bleed. At the age of 20, she got married, conceived, had an uneventful pregnancy. Now, remind you, her workup for hypertension was not complete despite that previous episode of a hypertensive bleed. Because she was slightly overweight, someone had labeled her as systemic hypertension. Again, at the age of 24, she came with headache, found to have high blood pressure with evidence of diaphoresis. And this was perpetuated by going to the toilet. Now, you can see over here, the CT scan showed a vascular lesion inside the bladder, and the MRI confirmed it. So the MIBG scan after 3 days showed persistence of isotope inside the bladder, confirming a bladder pheochromocytoma. She underwent a partial cystectomy, and the post-operative period was uneventful. And this is the biopsy showing this lesion within the bladder, and the staining, as you can see over here, is positive inside the bladder, and this is a pheochromocytoma of the bladder that you can see. Post-operative follow-up shows total remission, and the patient is doing extremely well several years later. This is our publication in connection with the bladder pheochromocytomas. It's a very rare condition, and in fact, most of them are not truly intramural inside the bladder. They are within the pelvic, in the parametrium, more than inside the bladder. So when you see a patient who has episodes of palpitation, sweating, and high blood pressure, it's not always a fear. In fact, commoner things include panic disorders, paroxysmal atrial tachycardia, which can also present with Cushing syncope, menopausal symptoms, which can be very florid with severe rises in blood pressure, vasodilating headache, migrainous headaches, which can mimic pheochromocytomas with rise in blood pressure, and of course, hypoglycemia in a patient who has diabetes can be almost exactly like a fear with palpitation, sweating, and rise in blood pressure. In summary, an attempt to look at a syndromic association with fear and paragangliomas is critical. Genetic testing is very important to look for, and it improves prognosis and leads to cost-effective prophylactic treatment in individuals, reducing morbidity and mortality enormously. So genetic testing should be done in all patients with fears and paragangliomas. Isotope scans using MIBG and more recently dotatate PET may be required, and isotope ablation can be done in some patients. And teamwork, this is the key to our management over here in Velo. Endocrine surgeons, endocrinologists, nuclear medicine specialists, and medical oncologists all should work together for the betterment of these patients. Switching now to hyperaldosteronism, 32-year-old lady came with recurrent episodes of flaccid quadriparesis, known hypertensive for 3 years, blood pressure of 170 by 110. When she came to us, she was on calcium channel blockers and beta blockers, and she had evidence of left ventricular hypertrophy with a loud A2. She also had persistent proximal myopathy. Sodium was borderline high, potassium was low, and bicarbonate was elevated. Hypokalemic alkalosis. She had U waves on the ECG besides LVH, indicating chronic hypokalemia. And this is her CT abdomen, which showed a left-sided suprarenal lesion, reconfirming the presence of the lesion over here. So aldosterone levels elevated, renin suppressed, indicating that this was a hyperaldosteronic syndrome. This can be commonly missed in mild disease. In fact, periodic paralysis is present in 50% of patients who have adrenal tumors. But in milder disease, you may just present what might be similar to a systemic hypertension. The treatment of choice medically is using spironolactone, and calcium channel blockers also work pretty well, and ACE inhibitors, and of course doing surgery once you have a well-localized lesion. This is a classical tumor, in fact, from the archives from our pathology department, 50 years old, a classical aldosterone-producing adenoma with this yellowish appearance indicating a fat-rich tumor. And this is the classical adenoma, as you can see over here, which basically shows evidence of a water-clear appearance. This is because the hematoxylin erythrin staining is washed out when the tumor is fixed, and these are the fat within the cells. Now, this is a landmark paper published. It's really wonderful because it's almost 58 years ago, and it is so visionary. Published by Jerome Cohn, the man whom the syndrome is named after, and what it describes is fantastic because he talks about hyperaldosteronism being present before potassium actually drops. And today we recognize the condition of normokalemic hyperaldosteronism, which may be present in almost 40 to 50% of patients. A large proportion of patients with essential hypertension, systemic hypertension, may have primary aldosteronism. And Jerome Cohn pointed that out almost 58 years ago. Incidental cortical adenomas without hypertension could physically appear to be the same. And once again, Jerome Cohn predicted adrenal incidentalomas before the era of the CT scan. Primary hyperaldosteronism is responsible for 5 to 13% of cases of systemic hypertension and makes up 0.6% of adrenal incidentalomas. So when you have difficult to control hypertension with maximum doses of 3 medications, the first thing you should look for, even if they do not have any syndromic symptoms or hypokalemia, check renin and aldosterone levels. As long as they are not on spironolactone or epinephrine, you can do this. 3% of hypertension in patients in a primary care setting and 39% of patients with resistant hypertension can have hyperaldosteronism. 6 to 10% of hypertension patients, for difficult to manage hypertension, you should consider primary hyperaldosteronism. Let's switch now to Cushing syndrome. 30-year-old lady, a G2, P1L1 at 18 weeks of gestation, came with loin pain for 2 months and headache and dizziness with severe hypertension. She did not have any other associated symptoms. On examination, she had no Cushingite features, but she had bipedal edema. She had evidence of LVH, A2 was loud, and there was a large bimanual palpable lesion in the loin. Systemic blood pressure was extremely high, and she had grade 2 hypertensive changes, no virilization. Her potassium was very low, her bicarbonate was elevated, and her liver function tests were normal. Her cortisol levels were high, but then in pregnancy, by the time you reach the second trimester, the cortisol levels will be elevated. And even the DEXA suppression can be falsely non-suppressed. So it doesn't mean much. Even checking these other hormones, well, aldosterone, difficult to interpret in pregnancy. She definitely did not have catecholamine elevation, and this was done in the pre-metanephrine era, but the VMA levels were well within the normal limit. She had an increased urinary potassium excretion, and she had LVH on the echo. Now, the ultrasound abdomen showed a large tumor, and we reconfirmed it with a CT scan because she had life-threatening hypertension. We went ahead with the CT, and you can see a very large left-sided lesion. We did not do a contrast scan over here. So the differential diagnosis, a large cortisol-producing adrenal tumor, but because it's so large, you should think of a adrenocortical carcinoma. FEO was another remote possibility. Blood pressure was difficult to control with 5 medications, and she had a spontaneous miscarriage. Subsequently, even after the miscarriage, the cortisol levels were found to be high. She had surgery, and there was a large tumor, much larger than what was witnessed on the CT scan, and she did well post-operatively. Histopathology showed this undifferentiated malignancy, polydifferentiated malignancy with mitotic figures, irregular cells, and local capsular infiltration. So she had some persistent hypertension. In view of capsular invasion, she was given radiotherapy. She could not afford mitotane, which is a treatment of choice for adrenal malignancies, but she's still doing well. In fact, now it's almost 10 years, and she's doing pretty well. 19-year-old medical student comes, this is his appearance, with progressive weakness, with hypokalemia and hypertension, also low back pain and psychosis in the second year of his medical studentship. His glucose levels are also elevated. So hypokalemia, hypertension, diabetes. Think about a possibility of Cushing syndrome. What do you think? Young man without overt Cushingite features but has hypokalemia, hypertension, and diabetes. Well, young male with hypertension and diabetes, pigmentation, rapidly progressive symptoms. Think about an ectopic ACTH producing syndrome. So this is his appearance. By the time he reached fellow, he had developed facial puffiness and pedal edema and papules all over his face. His cortisol levels were elevated at all points of time. The post-dexamethasone suppression tests were elevated, and the ACTH levels were through the roof. 32,000 after DEXA suppression, and the urine-free cortisols were elevated, and the ACTH levels were also markedly elevated. CT abdomen showed bilateral adrenal hyperplasia, and his CT thorax showed evidence of a thymic mass, which was confirmed with a Dotanox scan. Surgery was performed with a medial sternotomy, and a thymectomy was done. The thymus was found to be adherent to the innominate vein and had to be shaved off, and this was a malignant tumor once again. So he needed chemotherapy, and he did fairly well after that, and is still on follow-up with us, doing very well. Finished his MBBS and is studying hard for his NEET examination. So let's look at a broad clinical approach to our cases. For difficult to control hypertension and with maximum doses of 3 medications, please think of secondary hypertension. An age of presentation less than 30 years. Even in older patients, if you have any of these symptoms, pigmentation, palpitations, weight loss, periodic paralysis, polyuria due to not just diabetes, but due to chronic hypokalemia, fever, arthritis, think about vasculitic problems, and family history. Besides endocrine tumors, think about adult polycystic kidney disease and familial glomerulonephritis. Look for Cushingite features and acromegalic features. Severity of hypertension in terms of the grade of retinopathy. Look for features of MAM2, Turner syndrome, to look for coarctation of aorta, and radiofemoral delay, skin lesions, palpable kidneys, and abdominal bruit. These are the baseline tests which you can do in your setup, an ESR or a CRP. Creatinine levels to rule out chronic renal failure, which is, of course, a very common cause for secondary hypertension and can come incidentally in young people. An ultrasound with a renal artery Doppler and a 24-hour urine protein when you're thinking of renal involvement. The baseline tests you measure catecholamines, metanephrines, and the aldosterone and renin levels, as I mentioned, are very important. A CT abdomen can pick up most causes for secondary hypertension, and along with the renal artery Doppler, that picks up about 80% of patients with secondary hypertension. In certain cases, of course, you need to do a digital subtraction angiography, especially in certain cases of vasculitis and doing a vasculitic workup, and of course, a renal biopsy when it's relevant for glomerulonephritis. So I'd like to thank the ACP once again for this opportunity. My colleagues who have worked with me over many years, my colleagues in medical endocrinology, surgical endocrinology, nuclear medicine, pathology, radiology, our biochemistry department, and all our endocrine former staff, current junior staff, and residents. Thank you for your patient listening.
Thank you, Dr. Nihal, for the excellent presentation where you have actually taken us through pheochromocytomas, paragangliomas, and then you have shown us the importance of hyperaldosteronism as an important cause of hypertension. You've also discussed about Cushing syndrome. I think you have extensively covered all the important aspects of endocrine hypertension, although there are many other conditions which can have hypertension, which are not, I mean, the major manifestations. The other manifestations are the important ones there, like hypertension being present in acromegaly, hypertension being present in hyperparathyroidism. Those are also other issues, but I think you have covered the ones which need to be addressed effectively, and you've given us a good approach, shown us very good cases, illustrative cases where we could where you have managed these problems. I think I thank you for the excellent presentation. I am looking at any questions from the audience. I think there are a couple of questions. There's a question from one of the participants who's asking about cortisol. How often, how should it be done? He is asking whether it should be done once or twice, but I think, would you like to just...
So I think, thank you, Rakesh, for the question. Basically, when you're looking for a cause of hypertension, if you're thinking of Cushing's, you do a screening test first. Now, if you're thinking, the commonest cause for Cushing's, of course, is exogenous. And in most cases of exogenous Cushing's, unless you're taking oral hydrocortisone, your cortisol is more likely to be suppressed. So, especially with the common ones used like dexamethasone or betamethasone, it's going to be grossly suppressed. If you're thinking of endogenous, and if it's not an adrenal tumor, then it's going to be ACTH producing and you're pigmented, then you go for a dexamethasone suppression test as your primary screening test. So that would be doing a 1 mg dexamethasone suppression test, giving 1 mg of dexamethasone at midnight and checking an ATM cortisol in the morning. Because be careful, because pseudo-Cushing's could be present in morbidly obese people, those who have depression, and those who have obstructive sleep apnea. So you could have a falsely elevated cortisol in such situations.
I just want to ask you one more question about hyperaldosteronism. Would you just go by the biochemical diagnosis and go for if there is a nodule on seen in the adrenals, would you like to excise that, or would you do you think that we need to go for AVS adrenal venous sampling in
Sure.
each of these patients? How what would your approach be broadly?
Thank you so much for mentioning that. It is very relevant. Just due to lack of time and going beyond the scope of the lecture, I didn't actually mention it. But there are a proportion of patients wherein you may have asymmetrical adrenal enlargement, you may have cystic changes on one side, and of course, you can be misled totally into thinking that one side may be the side which is actually producing aldosterone, where it might be the opposite side. So doing an adrenal venous sampling, selective venous sampling is actually a way to go about things. Having said that, there are certain limitations over here. One of the biggest issues here is in certain patients, practically speaking, particularly in India, are patients who come with severe disease. And they are already on spironolactone or epinephrine. They may be on 4 medications. Now, you may have to actually withdraw the spironolactone before you do an AVS. So, in that situation, you may be faced with a situation where severe hypokalemia might become a problem. And so this is one of the issues here. The second major problem is there are few centers or very few centers in the country which actually do this with competence. And there is a learning curve. So when you're doing it, invariably, there are technical issues in cannulation, etc., which might be there. And so you can actually get false negatives because of technical issues and the learning curve in itself. So, but yes, it's something which this country should strive to master more. But there are a few centers which do it, but I don't think anyone is really up to it in terms of huge experience as far as this is concerned.
Yeah, there's a question about apparent mineralocorticoid excess with licorice ingestion. Would you like to?
So thanks so much for that question. And I think the last one at the bottom is really important. So licorice ingestion is a common problem, particularly in the Middle East, but also in India. And we all know that licorice is something which tastes absolutely fabulous after a fast. And particularly after Ramzan in certain parts of the country, people do take a fair amount of licorice during the iftihar, and can actually present with sudden episodes of weakness. They may not actually recognize it as periodic paralysis, and it comes and goes. But we have had people actually taking licorice and presenting with periodic paralysis in this situation as an apparent mineralocorticoid syndrome. Now, little syndrome can present in adults, but more often than not, it presents at an earlier age group. And in those situations, of course, the aldosterone and renin levels will be suppressed. It could be familial in certain situations and could present with severe hypertension as well.
Thank you for that, Nihal. What I would like to ask you is one more quickly about FIOs. We were always taught about the rule of tens. Now you're saying that it's likely to be a rule of 30. You could just clarify that.
So I think the rule of 10 is probably outdated, and maybe we should be talking greater than the rule of 10, because I've already highlighted the fact that there may be a good number of people who actually present early. And once you start doing familial screening for FIOs, you can actually start having normotensive FIOs in quite a few people. We have seen quite a few people have come with now going in for prophylactic adrenalectomies because the adrenals are obvious on imaging, but they still don't have hypertension in them. Biochemical screening being negative is common. In fact, the opposite. When you are on antidepressants and you're even stressed out, you can have borderline high catecholamine levels. So I think that looking at the clinical syndrome, very often asymptomatic patients can also be there in some. So, and malignancies, like I mentioned to you, could be present on long-term follow-up. So it may be more than 10% having malignancies, and pathology being, genetic syndromes being up to around 30%. So the rule of 10% is largely broken right now. I think we should be saying the rule of 20 or 30% in many situations.
Yeah, I think that's more and more because of the awareness and the fact that we're able to test better and evaluate better and do the genetic screening that
absolutely,
we have.
Rakesh.
So I think we'll conclude now because we've had a very excellent discussion, and we'll move on to the next presentation. We thank Dr. Nihal for the
Thank you so much.
presentation and all the clarifications that he's given about the queries that were there from the audience. Thank you, Dr. Nihal. So we'll move on to the next presentation. We have with us Dr. Vijayata Sengar, who is from Baroda, from the Maharaja University of Baroda, and she is from the Department of Food and Nutrition and the Faculty of Family and Community Sciences. She has over 13 years of experience in teaching and research, in addition to 8 years of experience as a diabetes counselor. She has more than 11 awards to her credit, including the Young Scientist Award in Community Nutrition at the 45th Annual National Conference of Nutrition Society of India held at Hyderabad in 2013. And she has been invited as a researcher for 4 international interdisciplinary symposia held in Oxford, Cambridge, London, and several other places. So I think she's a a good researcher who has been doing a lot of research in the field of dietetics and has done a lot of educational activities and has participated in many conferences. So I invite Dr. Vijayata to give us this interesting talk on diet for the doctors.
Thank you, Dr. Rakesh, for the introduction. At the outset, I would like to thank Dr. Anuj and Dr. Amit and ACP for inviting me for the talk today. Hope I'll be able to do justice to the topic given to me. Just give me 1 minute, I'll share my screen. Is my screen visible in the slideshow mode?
Yes, it is visible.
Yeah, thank you, Dr. Amit. So the topic given to me for today is nutrition and self-care for doctors. The outline of the talk would be medical workplace issues, systemic chronic inflammation, which actually is a special issue for doctors, physicians, because while going through the researches that have been conducted on physicians, I came across certain factors and which relate to long-term systemic chronic inflammation. So I've mostly planned my presentation towards SCI and what is the way forward in terms of nutrition and other lifestyle measures. So in 2020, there were over 1.2 million doctors registered in IMC, and around at that time, around 67,000 public and private hospitals were there. And with the advent of COVID-19 pandemic, we know how the work scenario has completely changed over the period. So the researches that have been conducted on physicians' health over the years have usually focused on work-related stress and burnout, mental health disorders such as depression and suicide, and substance abuse. However, there are very less researchers focusing on lifestyle behaviors and preventive healthcare amongst physicians. When we talk of medical workplace issues, it is a complex environment which can be stimulating and exciting for a few doctors and maybe stressing for the others. Majority of the researchers that I came across globally or in India, doctors have reported certain issues like work-related stress, inadequate sleep, physical inactivity, poor diet. As Dr. Amit also mentioned in the beginning that this is like the work-related stress, inadequate sleep is usually faced by the early career physicians. So that is why it becomes all the more important, because for a long period of time, these issues will be there for these early career physicians, which might lead to SCI in them. So when we talk of causes and consequences of low-grade SCI, it was seen that SCI-related disease rates have been increasing in westernized countries more. Whereas in non-westernized population, who are normally adhering to the old diets, lifestyles, they're not in those high levels. So if you see, most of the causes of SCI that are shown in this figure are experienced by the physicians. Disturbed sleep, isolation and chronic stress, diet, dysbiosis, obesity, and physical inactivity. Consequentially leading to metabolic syndrome, cardiovascular diseases, cancers, depression, etc. So let's start talking about these factors. The first is stress that I have taken up, because work-related stress is one of the major issues which is well documented amongst doctors in several studies. Stress affects almost all the body organs, being the musculoskeletal system, respiratory system, cardiovascular system, endocrine, GI, nervous, or reproductive systems. It was seen in many studies that tension type headache and migraine headache was associated with chronic muscle tension in the area of shoulders, neck, and head, which was reported by most of the physicians. Musculoskeletal pain in the low back and upper extremities were also linked to stress, especially to job stress. Stress and strong emotions can present with symptoms like shortness of breath and rapid breathing, as well as when long-term stress was seen in physicians, it was observed that there were increase in heart rate and elevated levels of stress hormones, and there was an increase in blood pressure also, which actually increased the risk for hypertension, heart attack, and stroke. When we talk of the endocrine system, a chronic stress or long-term stress results in an impaired communication between the immune system and the HPA axis. This impairment basically leads to the development of numerous physical and mental health conditions, which includes chronic fatigue, metabolic disorders, depression, and immune disorders. Again, stress also affects the brain-gut communication and may trigger pain, bloating, and other discomforts. So studies have shown the sensation of pain or the feeling of pain is much higher in people who are stressed compared to non-stressed population. Chronic stress, again, over a long period of time can result in long-term drain of the body, especially because the ANS system continues to trigger physical reactions, which causes a lot of wear and tear in the body. And it is also important to understand here, it is not the chronic stress to the nervous system which is problematic, but the continuous activation of the nervous system because of stress, which affects the other body systems, is problematic here. Apart from stress, a lot of physicians have reported a lack of time for socializing, which leads to isolation at most of the times. And one of the consequences of poor social health is depression and also a higher rate of suicides in some of the physician populations. The social health, when we say, is the ability to form healthy interpersonal relationships. If you see, I've placed two figures here. One is a healthy interaction between doctors, and the other one shows how we are working nowadays. Because of COVID, when we were in isolation, and also because of the busy life schedules, this is the current scenario, which impacts our social health. A survey conducted by Wall Street Journal showed that most of the people reported of using social media for connecting with friends and family, which is actually not social health. This is the use of social media. So we need to understand the difference between social health and the use of social media. As you can see in the second figure, the amount of time being spent on social networking has been increasing over the years. It is well known fact that good social health builds a healthy immune system. Working to maintain social health also helps in strengthening the ability to fight depression. Poor social health will reduce the productivity and sharpness of the mind. Therefore, it is very, very important that people apart from working hard, they should also have a good social health. Social health is a big issue even in the students community these days, because as soon as we are free, we are on one or the other devices. So we should consciously try to improve our social health, because people with poor social health are likely to end up with inflammation and other chronic health conditions. Another factor which was reported in most of the studies was physical inactivity. So physical inactivity, we all know that increases individuals' risk for various NCDs because it is linked to obesity and in particular to excessive visceral adipose tissue. So visceral obesity accelerates the aging process and increases the risk of various cardiometabolic, neurodegenerative, and autoimmune diseases. Several researches that I went through globally and in India, it was observed that physicians are on an average are getting 20 to 25 minutes per day of total exercise, which is usually mild exercise or easy walking. Inadequate physical activity, which is considered as something less than 150 minutes of moderate to heavy exercise per week, was reported by 52 to 86% physicians in various studies. And few factors that reported were advancing age, female gender, lack of time, fatigue, lack of energy, and motivation. Coming to the next factor, sleep, which is again a very important factor in development of SCI in physicians. The reason being due to their night shifts or the changes in the shifts or due to long working hours, it is mostly sleep quality that is affected. So in addition to physical inactivity and diet, there have been a lot of changes in the sleep quality, which promotes SCI and insulin resistance, thus increases the risk of obesity, type 2 diabetes, CVDs, and all-cause mortality in physicians. Exposure to blue light, again, it causes circadian rhythm disruption, which again in turn promotes inflammation. So we are all used to using different gadgets at workplaces as well as at home. And this exposure to blue light is affecting the quality of sleep. As an example, night shift work has been found to increase risk for the metabolic syndrome and is suspected to be a causal factor for type 2 diabetes, obesity, and CVD. So it is very important to time the sleep and also the quality of sleep. Okay. Nowadays, we have a lot of applications which will measure our sleep time and the quality of sleep, the amount of sleep we have, the time we had for deep sleep and other things. So that is very important to be monitored for physicians also. Microbiome dysbias is another factor which leads to SCI, development of SCI, and it's mainly studies in obese individuals and obese women have shown that gut microbiota composition and microbial gene richness, these were correlated with increased fat mass, pro-inflammatory biomarkers, and insulin resistance. So mostly, if we have physical inactivity, if we have poor sleep quality, poor diet, then it might also affect our gut microbiota composition and thereby causing inflammation. Coming to diet and nutrition. So the typical diet that nowadays we are following is low in fruits, vegetables, and other fiber and prebiotic rich foods. And it is high in refined grains, alcohol, and ultra-processed food. And this is one of the reasons for increase in inflammatory markers. When we consume processed foods which have been cooked at high temperatures and in low humidity conditions, they, although are appetite increasing and are linked to overnutrition or they give you a lot of calories, but they do contain a lot of advanced glycated end products and lipoxidation end products, which leads to obesity and inflammation. High glycemic load foods such as isolated sugars and refined grains again cause an increased oxidative stress and activates inflammatory genes. High salt intake surprisingly has shown to cause adverse changes in gut microbiota composition. And it was seen in studies, both in animals and humans, when they were fed high-fat salt diets, it reduced the lactobacillus population in these animals and humans. Several studies have shown again, longitudinal study. This was a longitudinal study which showed that a 10% increase in proportion of ultra-processed food consumption was associated with a 14% greater risk of all-cause mortality. Along with these factors, along with these changes in the diet, deficiencies in micronutrients, especially zinc and magnesium, which are usually caused by eating refined foods and foods that are low in vitamins and minerals. These impact the resolution phase of inflammation. And long-chain omega fatty 3 acids again have shown to change, to basically modulate the metabolism and inflammation in humans. Another study which was done by NCHS few years back on American adults, it showed that high dietary trans fats, fatty acids, low dietary omega-3 fatty acids, and high dietary salt were the major dietary risk factors associated with greatest mortality in these people. Another systematic analysis of dietary data from 195 countries identified poor diet as the major risk factor for death in 2017, with excessive sodium intake being responsible for more than half of diet-related deaths. Finally, when we talk of diet and nutrition, when it is combined with low physical activity, consuming hyperpalatable processed foods that are high in fat, sugar, salt, flavor additives with increase in age, these amplify the inflammatory responses in physicians. Physicians are also exposed to several factors which are leading to SCI in long term. Thus, a holistic approach which integrates diet, physical activity, and stress management may help in reducing SCI and its consequential effects. So what is the way forward? So coming to the first topic, that is nutrition. So several significant relationships have been changed. When you make changes in the nutrient intakes, there are changes seen in the inflammatory mediators. The major changes are increased consumption of omega-3 fatty acids, substitution of non-hydrogenated unsaturated fats for saturated and trans fats, consumption of diets high in fruits, vegetable, nuts, and whole grains, reduce intake of excess salt and refined sugar. So as nutritionists, we usually use the whole diet approach, where the diet includes whole grains, fruits, vegetables, with reduces saturated fat, salt, and sugar. And this whole diet approach has been known to decrease inflammation. For example, when we talk of an ideal plate, it's 1/4 healthy protein, 1/4 whole grains, and half of the plate is of fruits and vegetables. So if you see this, this is the My Plate for the day, which has been proposed by ICMR NIN. And it shows clearly half of the plate is fruits and vegetables, where 350 grams of vegetables and 150 grams of fruits should be included in the diet, excluding potato. It can be included in cooked and raw form as salads or whole fruits. Preferably, you should be using fresh fruits. You should avoid juices. And you should use different varieties of cooking oils, vegetables, fruits, and nuts, so that you can get a variety of nutrients, the phytonutrients which are there in these foods, vitamins, minerals, and other bioactive compounds which are known to reduce inflammation. So coming to omega-3 fatty acids and selenium, again, omega-3 fatty acids act both intracellularly and extracellularly to produce a number of anti-inflammatory effects. And therefore, we should try to introduce more of omega-3 foods in our diet, along with foods containing selenium. When we say substitute non-hydrogenated unsaturated fats for saturated and trans fats, we mean that more of unsaturated fats, your PUFA and MUFA, should be included in your diet, because these are related or associated with decreased risk of CHDs and reduction in inflammatory markers. Modern day diets are predominantly high in trans fats and saturated fats. Researchers have shown the ratio of omega-3 to 6 between 1:10 and 1:15, which is not suitable. Ideally, it should be 1:1, or up to 1:4 and 1:5 is also fine. Omega-6 fatty acids are pro-inflammatory and omega-3 fatty acids are anti-inflammatory. That is why this ratio has to be a little bit lesser. Okay. When we talk of trans fat foods, these are the food groups where we get trans fat foods, fats and oils, baked foods, fried snacks, processed and packaged foods, and reheated and reused oils. So all our fried food items, the samosas, kachoris, jalebis, have a high amount of trans fat. We should, and the bakery foods, we should try to avoid these foods. What can be done to reduce trans fat foods from our diet? First, we should learn to read the nutrition facts and food labels carefully, and look for hydrogenated oils or partially hydrogenated oils or shortenings in the ingredient list. So if it is there, we should avoid those foods. We should use vegetable oils which are rich in poly and monounsaturated fats. I missed this here. If you see this figure on the right hand side, the blue lines indicate the omega-6 fatty acid. So if you see sunflower oil, corn oil, soybean oil, cottonseed oil, they have a high amount of omega-6. So as I said, we should have a healthy ratio of omega-3 to 6. We should try to reduce these oils in our diet. So we, as a nutritionist, we suggest that we should keep on changing the oils that we're using so that we get benefits from all the oils. Okay. Limit the use of processed and packaged foods. Do not be dependent on these packaged foods. We can prepare our own snacks at home, which was an usual practice in our families in earlier years. Okay. Opt for healthy snacks which are naturally free of trans fats, like your mixed nuts, sprouts, salads, fruits, etc. Do not use a reheat oil or reuse it for frying, and avoid using vanaspati for cooking and frying. Diet high in fruits, vegetable, nuts, and whole grains provides us vitamin A and carotenoids, vitamin C, omega-3 fatty acids, vitamin E, and zinc, etc. When we talk of vitamin A, carotenoids, omega-3, and zinc, it has been seen that it is negatively correlated with several pro-inflammatory mediators. So a negative correlation between vitamin A and carotenoids with pro-inflammatory mediators can be explained by the antioxidant properties of vitamin A. And we can get our vitamin A and carotenoids from yellow, orange, red fruits, liver, meat, fish, etc. Zinc also possesses antioxidant properties and has been shown to reduce reactive oxygen species as well as the production of pro-inflammatory cytokines. Similarly, vitamin D has been recently found to play an important role in modulation of immune and the inflammation system. And that is why vitamin D again becomes very important. Now, vitamin D deficiency was seen in a lot of adult population and in physicians too. The reason being, we do not have a sunlight exposure these days. We are usually working inside. So sunlight is one of the easiest ways of activating vitamin D, which is already there in our body. But if we're not able to do that, then there are certain other food sources which can be taken, or else supplements can be suggested to these people. Similarly, similar to vitamin D, even vitamin B12 deficiency is increasing nowadays, and low serum B12 concentrations were found to be associated with pro-inflammatory cytokines. I remember when we were taught long back, 25 years back, we were told that B12 deficiency is not very common in India because we were not very hygienic people those days. But nowadays, we follow a lot of hygiene routines and other things, and B12 levels have gone down. So what we can do to increase B12 levels, either we can include the food sources of vitamin B12, or we can use processes like germination and fermentation, especially in pulses, cereals, vegetables, to increase vitamin B12 levels in these foods. So summing up the nutrition, diet and nutrition part, we should eat fruits, vegetables, legumes, nuts, and whole grains in our diet. For snacks, we should choose raw vegetables and fresh fruits. We should avoid overcooking vegetables and fruits as it may lead to loss of important vitamins. If you're using canned and dried fruits or vegetables, then we should use varieties which do not have added sugar or salt. Inclusion of fermented foods will also aid in improving gut health. The most important key to healthy diet is portion control. Usually in India, we are used to having large portion sizes. So we should try to understand what is the actual amount of food that we should be eating in a day. So as I showed you the my plate, this is for a 2000 kilocalorie diet. This is the amount of food that a person should be consuming in the whole day. Water is essential for life. Drink at least 8 to 10 glasses of water. In summers, we can increase up to 12 to 14 glasses even. And along with water, we can consume other drinks like fruits and vegetables, which contain water. And we can have our lemon juices, which should be unsweetened, diluted with water, tea and coffee, but limit the amount of tea and coffee. One thing that I would like to tell you here is we normally suggest people to drink their salads these days, because the usual complaint for consuming salads is that it takes a lot of time because you have to sit and chew it for long durations. So what do is we suggest people to make smoothies. So you can have your green smoothies, or you can have your vegetable smoothies, fruit smoothies, without straining, without adding any salt and sugar. You can add these super seeds like pumpkin seeds, sunflower seeds for added benefits, and a few nuts to your smoothie, and you can carry it along with you if you want to the workplace even. Eat moderate amounts of fat and oil, consume unsaturated fats, choose white meat, which is from poultry and fish, which is generally low in saturated fat compared to red meat. Avoid processed meat as it has a high amount of salt and fat, and opt for low fat or reduced fat versions of milk and dairy products. Eat less salt and sugar. Salt intake should be limited to less than 5 grams a day, and it preferably should be iodized salt. Limit your intake of soft drinks and sodas and other things which are high in sugar. Choose fresh fruits instead of sweet snacks such as cookies, cakes, and chocolate. And a recommended sugar intake is somewhere around 2 to 3 teaspoons per day. If you want to avoid sugar completely, even that can be done. What is equally important in changing a diet is our intentions, behaviors, and perceptions in changing our dietary behaviors. So we should remember that the type of food we eat impacts our disease risk. Mindfulness and intention affects all behavior, whether it is what and how we eat. Healthy eating has to be an enjoyable way of life. So we should not call it a diet. We should actually develop it as a habit. Taste must accompany nutritional science. So nowadays we have been working since years on how to improve taste of healthy foods, because people always say whatever is healthy is not tasty, but that is not the case. We can make it much more tastier and follow our healthy diets. Set attainable goals for yourself, establish new habits, establishing new habits takes a lot of time, but we can do it, provided we are motivated to do it. And be reminded how you eat impacts your advice to the patients and their families. When we talk of physical activity, exercise matters. We should exercise at least for 30 to 60 minutes a day. It is not necessary to exercise continuously. You can divide it into 10 to 15 minutes activities several times through the day. Recommended, WHO has recommended 150 minutes of moderate intensity exercise per week. And it was seen that if it was associated with lower risk of CVD mortality by 23%, CVD incidence by 17%, and type 2 diabetes incidence by 26% when a given population was followed up for 12.8 years. These are some of the benefits of physical activity. It builds and maintains healthy bones and muscles, reduces the risk of developing obesity and chronic diseases. One of the most important benefits is it reduces feeling of depression and anxiety and improves sleep. Simple modifications at the workplace can be done, like installing secure bike racks, having shower facilities on site for those who exercise before work or during their lunch break, encouraging team entries to events such as local walks and runs. It may help in increasing physical activity at workplaces. Coming to stress management, I have placed just one image over here, which actually talks of stress management holistically. So these are the happiness chemicals that we talk about: dopamine, serotonin, oxytocin, and endorphin. So dopamine is the reward chemical. So whenever we complete a task, we should actually celebrate those little wins, but remember, we should not celebrate it with unhealthy foods. Usually the behavior is such that whenever we do something good, we go out to eat. So these celebrations should be something else, like going for a long drive, or maybe going for an extra walk, or maybe half an hour extra of sport that you like. But be very careful with how you celebrate these little ones. But do celebrate, because it increases the amount of dopamine in your body. Okay, eating food and doing self-care activities are equally important. Serotonin, which actually stabilizes our mood, is increased when we are meditating, running, or we are sitting under sunlight, taking a walk in nature, swimming, or cycling. So try to identify which activity suits your time schedule and your liking, and start following it. Oxytocin is known as the love hormone, which can be increased by playing with a pet, playing with a baby, or holding hands, hugging your family, or by giving compliments to others. Endorphin, again, which is the painkiller, it is increased in our body when we go for laughter exercises. Essential oil therapies also help. Watching a comedy movie increases your endorphin levels. Exercising also increases the endorphin levels. So we should also include these activities and these pointers. We should always remember to incorporate in our daily life in order to take care of the stress. So the key messages are: one, eat variety of foods from various food groups. We should not limit ourselves to just a few food groups in a day. Have 4 to 6 meals in a day. Use minimum oil, sugar, and salt in your diets. Exercise regularly for 30 minutes, at least 5 days a week. Meditate, read self-help books, identify your hobbies, learn new skills, travel new places, practice gratitude, self-compassion, and love yourself. A lot of studies have shown self-care as one of the factors which is lacking in physicians. Because they do not get time for themselves, they usually do not work on this aspect of life. So do follow self-care routines and love yourself, as I said, and don't miss to enjoy your journey, which is your life. Thank you.
Thank you, Dr. Vijeta, for the excellent, your presentation where you have not just spoken about. We thought you were speaking about nutrition, but you have gone beyond that. You've spoken about every aspect about not only physical activity, stress management, and so many aspects that you've spoken about. I think you've given a very holistic view on a healthy lifestyle. So I thank you very much for the excellent presentation, and I'll let us see if there are any questions from the audience. Um I don't see any questions. You have presented it so wonderfully that there is no question from the audience also. I mean, they are all very clear about the presentation.
There
I
is
would,
one question I would
yeah.
like to ask to Dr. Vijeta. You said very rightly, whatever points have you raised, there is no doubt in those points. But what is the problem remaining with the early career physicians? That is the biggest problem of the time management. Time management and how to adjust the schedule with their diets and exercise. Most of the early career physicians, as you very rightly said yourself, that they don't get for themselves. So most of the early career physicians don't get enough time for the exercise. They don't uh, uh, they don't know what to eat and not to eat, and whenever they are going out of the house, whatever is kept, they just had that and went away. It has happened to, I think, all of us in our early career time. So the foundation of the bad health starts from there only. Because after 10 years or 15 years, even if we regularize our schedule, still the things has been so many bad in our body, in our shape, in our deposition of the fat. So it takes a lot of time and lot of energy and to make ourselves again in the healthy from the health point of view. So I have seen few of the clinicians doing some scope of activities in their clinics. For example, I have seen one of the clinician that he has made five small chambers, and in those chambers, patients were sitting. Instead of calling the patient to his chamber, he goes to that chamber and checks the patient. So his own movement keeps on going. That I can understand every physician may not be having that much of enough space to create five small chambers for the patients and similar kinds. One of the ophthalmologists I have visited. So what was he doing? That he was keeping 2, 3 examination table, and patients were sitting there. Instead of asking the patient to come to his table or his chair, he was moving on those tables and those chambers. So in that way, physical activity keeps on going. So these are the few things which can be done to make the people moving, because many a times we see that people start doing the practice at 7 a.m. They keep on sitting at the same place. Some people even don't get enough time to take lunch, so they are continuing there, and they are just getting obese, and then they develop hypertension and metabolic issues related to that. So what do you think in that perspective? What will you suggest our
Like
clinic?
the first, yeah. The first thing I feel is, like, as you rightly said, some clinicians are able to make these changes, but we can always customize these things. Like, be it diet or physical activity, it can be customized, because it has to be customized, because each individual has a different set of routine, a different set of, like, in at home also different cooking practices are being followed. So what can be done is, one, it can be customized for individuals. The things that we need to follow is like, what I feel is, like, in my case also, if I start my day, I used to start my day early in the morning, and then it went on till late. But then slowly I started taking half an hour out of it somehow. So basically, when we talk about time management, we have to take out some time somewhere. So then I started going in for badmintons. It helped, because Badminton was a sport I was not going in for since long. So after 20, 21 years, I started playing badminton. So then it helps you in a lot of ways, not only physical activity, it helps in improving your like endorphin levels. So overall, your mood is good. The whole day is good. If you're not able to do it in the mornings, maybe in the evenings, sometime if we can squeeze out somewhere, or maybe like when we are in hospitals, instead of elevators or lifts, we can walk up and down the stairs, move around. So certain changes can be made. Similarly in diet, I'll tell you, like food, we know that whatever is cooked has to be carried. So whenever we think of changing the food habits of a person, we usually contact the person who's cooking at home. So whether it is the cook or the wife or the mother who's cooking, we usually talk to them and then counsel them. So changing dietary habits takes a lot of time. As you rightly said, these habits are formed early, much earlier in life. So it will take time to change, but we can always make changes, conscious changes in these dietary habits. Like
The
he
biggest problem, Dr. Vijeta, sorry to inter. Biggest problem is there when husband wife both are doctors and both are moving at the same time. And
yes,
in the early career days, many times it happens that people are not having cook and there is no. So both of them are doing something like that, and something. Sometimes they got something, sometimes they did not get something.
yes.
So these kinds of the things keep on running in their schedule. So
Mm.
that was my really perspective,
Yeah.
because once
For
there is
that,
no
I
cook,
feel,
to whom to tell it?
yeah.
We have to manage ourselves somehow.
Correct. For that, like a simple way that I feel like if you have a cook, maybe a helper at home who's going to cook, then what you can do is you can make a plan. Like at my place, what I do is we have a plan ready. Breakfast this, lunch this, all this should be made. So we have a chart for a week and we placed it in the kitchen. So my cook knows what she has to cook. And we always tell her a day prior to the like let's say if it's Monday, just check whether the items for Tuesday are there or not. Otherwise, when you're coming the next day, buy it and get it. So that is one of the easiest ways we have tried to work out that we at least get healthy food. So like as I said about drinking salads, we can always, it's just blending these fruits or vegetables in the mixer. It does not take a lot of effort. So we just have to take those fruits and vegetables, blend it and carry it with us. So we can carry it in school cases, or if you have a refrigerator at your clinic, you can keep it there and you can have it later on at any point of time. It's quite filling when you have nuts and like pumpkin seeds, sunflower seeds added to it, then it's quite filling also. So you can take care of one snack, which is a much healthier option. So a little bit of changes would be required. Yes, it takes a lot of time in changing the habits also, because it involves a lot of people. It's not only you, like you want to change your habit, but then it's the whole environment which has to change. So it will take time, but it can be done consciously.
Over to Rakesh, Dr. Rakesh.
Thank you, Dr. Vijeta. I think you have given excellent suggestions, and I think this is important, as Dr. Anuj has said, that it is like the legacy effect which we speak about when you're treating diabetes. We say that if you manage diabetes very well in the early years, then that legacy remains and people are protected from complications. Similarly, if we set up good habits, good health nutrition habits, and good exercise habits in early career, I think that keeps you going well without any health issues for a for a good period of time, where you don't have to be hampered by these issues when you are actually at the prime and you want to be good, want to be doing well, and that's the time when you will benefit from this legacy effect. So I think this is very important. I think I'll thank Anuj for actually thinking of this topic and keeping this topic, because I'm sure it's going to benefit a lot of people who are attending this session. And one more good practice which I was just saying, Dr. Anuj was showing many good practices which he has seen in many physicians. Maybe one other one would be probably standing at the table rather than sitting on the at the examination table. I think you can change your room in such a way that you have a table which is higher, and you can be standing and talking to your patients, and that way you get more time standing and more activity, more physical activity while I mean, while you can make the patient comfortable, make him sit down, but you could be standing, and that'll be another sort of good practice that can be followed. So I think I would now like Dr. Amit to say the final words if he wants to add something, and then he can conclude the session.
Thank you, Rakesh sir, for your excellent moderation. Both the talks were really very useful and relevant to present day scenario. And Dr. Vijeta Singer not only talked about nutrition, but she actually went into all the details, including stress management and a lot of things. So it was also very insightful. So we have got many key messages, and I must congratulate Dr. Anuj sir for thinking of this program, because in our times, there was nothing like this who can guide us, and nobody ever talked to us like this, that what you need to do when it comes to self-care, how to, and we talk about different topics like managing the practices, managing the finances, managing the health, nutrition, exercise. So I think it is going to be of great value for the early career physicians for whom this program has been designed. I would like to thank again Dr. Nihal Thomas and Dr. Vijeta Singer for delivering their talk on this wonderful platform. And Dr. Rakesh Shah sir, as usual, your moderation for both the talks is something which is very, very wonderful, and we all really enjoyed. It is already 9 p.m. We overshooted by 30 minutes, but we never felt that we are already late. And today we made another attempt, but we invited many of the fellows of American College of Physicians, and we could see they could not attend for the full time through this window, but many of them came and attended this program. They're all the fellows of the American College of Physicians or the member of the advisory council. So with this, with the permission of our governor, Dr. Anuj Maheshwari sir, I would like to conclude this program. And we will meet again in another episode of ACP India Case Files. And we are proud to say that now it is an award-winning series. And we will try to keep up the standard of this program, and we will try to improve with each and every program. Thank you everyone, and thank you all the fellows or the members of American College of Physicians who were watching this program live. Thank you everyone.
Thank you, Dr. Rakesh. Thank you, Dr. Vijeta.